I'd like to welcome everyone to the ethics rounds for today. The CME code is 18699 to obtain one CME credit for attending this session. And so I'd like to start off by saying that these ethics rounds are supported by the Ethical Advisory Committee, which is a committee of the Medical Staff Committee. I'd like to say we offer consultations 24/7. And I do mean 24/7. I tell people that I realize ethics became a bona fide ethics consultation service when we started getting consults at 4 o'clock on Friday afternoons. So I'm expecting that call in just a few hours. You could contact us by calling my cell phone number that's listed, place an order in Epic, or probably the best way is Tiger Connect. You could go under UMMC Ethics or go right to my name and send me a Tiger Connect message. So just want to say that this session is accredited by the University of Maryland School of Medicine. And again, you could obtain one CME credit and the code is 18699. Okay, the objectives of this session is that upon the completion of this activity, participants should be able to discuss ethical dilemmas in clinical practice and explain how to use an ethical framework for solving ethical dilemmas, which I frequently try to demonstrate as we go through these cases. And so, having said that, let's start off with any questions about anything? I'm giving you practice in how to interrupt me if you want, though it's not an interruption if I'm asking if you have any questions. Okay, all right, very good. So I'm going to start off with a quick case, just to warm up the audience, if I could say that. The patient is a 60-year-old female with COVID positive past medical history, CKD on dialysis aids, non-adherent to antiviral, sacral osteomyelitis secondary to chronic sacral decubitus ulcer, and history of reported prior stroke with unclear residual deficits. She is currently admitted in the setting of sepsis and severe protein calorie malnutrition, BMI of 14, whatever that means. That sounds pretty low. As per the social worker, there is a possible concern for neglect, given concern for poor home care as evidenced by medication non-adherence and severe cachexia. Adult Protection Services is being notified. On admission, patient was not moving either lower extremities and was found to have a left femur and ankle fractures on x-ray after external rotation was noted at rest. Patient is awaiting bedside orthopedic intervention, pin placement to stabilize the leg. Due to sepsis, patient does not have capacity to provide consent. So the orthopedics asked us this question: is the husband the appropriate surrogate decision maker to provide consent for the patient? So let me go to the first poll. Okay, so far we have 25. Okay, everyone's voting. That's really good.
Henry, can we know anything about the husband's decision at this time? What the husband's decision was as far as approval or not of the procedure?
Oh, good question.
Well, that's not fair, Dr. Silverman, because that's why you should answer not sure.
Well, I actually, when I got the consult, I was not sure what the husband was saying until I spoke with him.
Yeah, because right now I would answer not sure, but if the husband says yes, given the information I have available currently, I would be more inclined to say I'm okay with him making that decision. If he's refusing, then my intuition goes the opposite direction.
Okay, all right, good comment. So the issue was, and actually I got another consult with the same question the next of kin or the POA is being accused of neglect, and the concern is whether that POA should make decisions for the patient. So it's the issue of neglect, being charged with neglect.
I have a quick question though.
Sure.
The fact that the husband maybe is not taking care of her at home doesn't mean that he's not the appropriate surrogate decision maker. Those are two separate things.
This is what we're trying to find out, whether they're separate or not. On one hand, one could say that the husband is not doing things at home that aligns with the patient's best interests. And that may be carried over to the clinical decision-making. So these are all great questions. Let me end the poll and see what you guys said. So about half said yes, and 20% no, and the rest said not sure. So I think you guys asked a lot of good questions, and I already said the orthopedics is reluctant to obtain consent from the husband, and I saw the patient that afternoon and also spoke with the husband, and we discussed the patient's long illness and also her leg fractures. And initially, the husband expressed concern about whether the patient can undergo an extensive orthopedic procedure. And I said, well, the procedure is going to be bedside. It's a pin placement. And after that, he said he would agree with the procedure. So the basic concept here, which some people have already mentioned, is that on one hand, the patient is the legally authorized decision maker as per MD law. He has a legal and moral authority to make decisions that are in the best medical interest of the patient. Now, regarding decision making, there is a proposed investigation regarding possible medical neglect. However, that is not relevant as long as the husband is making decisions in the best interest of the patient. And I also put in the concept, if, however, the husband starts making a decision that does not appear to be in the best interest of the patient, then please re-engage ethics. Okay, so, the other thing I like to say is being under investigation it's not akin to being charged with a crime. So that's the other reason why the husband should be still considered the authorized decision making. So I agree. As now, having said that, someone asked if the husband is agreeing, providing consent, then is there an issue? And the short answer is it appears to be yes, because the orthopedics people did not want to proceed with the procedure until I wrote my note in Epic saying that it's appropriate. Okay. There's some activity in the chat box. Any further thoughts about this case? Because it came up twice this week about medical neglect.
So that was the next point I wanted to bring up, because oftentimes we see that question about neglect comes up very quickly without actually doing a deep dive. Is it possible that this person, the husband, I don't know him, he's doing his best, but his wife is very sick? As you mentioned, she has a long chronic illness, and we are getting to the point where she is today. Probably she declined over years.
Yes, right. That's a good point. That on one hand, he caring for his wife may be just too much for him. On the other hand, I guess we should have a low threshold to think about neglect. However, we should gather all the evidence, and like you said, we need to do a deep dive into
Henry, can I make a
issues.
suggestion?
Sure.
Have you ever used the family app guard? Do you know what the family app guard is?
The family app guard. Okay. Is it the same dimensions as the newborn app guard?
Well, the name was adopted, but it really is quite different. Basically, what you do with the family app guard is you evaluate emotions, motivation, and interpersonal dynamics involved in any case, but in this particular case here is called a family app guard. And you consider all the factors. And Murray Bowen talked about triangulation and families and the family system. So I think with this kind of an issue, this kind of a conundrum, whether he's capable, not capable, you look at the family app guard. That has to do with evaluating the family for adaptation, partnership, growth, affection, and resolve. So you really pull together, who else is in the family. It becomes a workable putty that you can work with. And triangulation, is like 3 people usually I'm talking traditional family, but you could define family however you want, trans, whatever, LGBT. But it's 2 people and children, or 1 person and children, however you define family. Family to me is a group of people living on an intimate basis with a past, present, future. So how they affect each other, if one gets sick or something happens, that affects the family and the extended.
Right. Larry, let me this is really interesting information about doing that psychosocial assessment. However, are you suggesting to use that APGAR score to determine whether the family member is the appropriate decision maker?
Yes, in a way, you can look at.
Okay, well, let me stop you there. I was hoping you would say yes, because the point I want to make is that we don't have the authority to assess family members' capacity to provide consent, because 1, that's an exam, and family members are not our patients. So we cannot assess capacity. Now, we could become concerned, and just like in this case, as long as they're making good decisions, that's fine. If they're not, then you take it to the ethics committee. Sometimes I get a call from the staff saying the family, every time they come in drunk, and are they supposed to make decisions for the patient? And I say, well, we cannot disqualify family members as legally authorized representatives. And again, as long as they're making decisions that appears to be in the best interest of the patient, then that's fine. Because if they're making a decision that's in accordance with patient welfare, actually with the sliding scale of competency, that's we only need to have a low degree of certainty about capacity. Okay, great. Well, Larry, why don't you share with me that AppGuard? I could see where that's relevant in other situations to assess where the family is coming from and the dynamics when we keep on having these end-of-life decision-making with families. Okay, good. Wow. Case 2, can the patient refuse COVID testing? A consult was requested regarding a planned outpatient procedure involving endoscopy with ultrasound to rule out pancreatic cancer. The patient had been experiencing abdominal pains for several weeks. He saw an oncologist who obtained a contrast CT that showed a pancreatic cyst. And however, hospital policy requires a negative COVID test 96 hours prior to the procedure. The patient is refusing COVID testing. Sorry for this picture. Obviously, that's vaccines, but this is just COVID testing. I couldn't find a picture with for a nasal swab. But anyway, this patient is refusing COVID testing based on religious grounds. He also said he had symptoms of COVID in December and hence does not need a test. More importantly, he feels it's a violation of the Civil Rights Act and hospital policy that patients treatment, in regards to treatment, patients should not be discriminated on the basis of religious freedom. So let me get, let me see what you all are thinking about. So let me, all right, so what do you think about this? Should a religious accommodation be granted to the patient? This case is really...
Right. Hey, Henry, I have a question. Chandana here from Neurology.
Yeah, right.
With nasal swab, what's the religious accommodation?
No, I'm just, he's saying he doesn't want COVID testing based on his religious beliefs.
Yeah, I mean, okay.
So, and he says,
And
if he doesn't get the test because of his religious beliefs, he is saying he is being discriminated. He is being refused treatment on the basis of his religious beliefs.
And he wants his pancreas cut open. That's okay in the religion?
He had, well, right. It's okay to undergo the procedure, get the operations, blah, blah, blah. Well, same thing with vaccine hesitancy. People may refuse the vaccine, but they want all the other bells and whistles, right?
I mean, exposure to the stuff is I don't know if it comes under the realms of the Venn diagram that we show for ethics, patient's autonomy, negligence and malfeasance, but exposure to the stuff is important here.
Oh, okay, good. So you raised a question, and a very important question, of whether there could be an exception.
I think, Ivan Zama here, I think this issue about religious accommodations is nonsense. The patient should get
Do you want me to cut that statement out of this recording?
No, it is nonsense. The patient should be tested. The patient should get vaccinated. If he needs to get clearance for cardiac clearance prior to procedure. Is he going to request a religious accommodation to get cardiac clearance? Is he going to request a religious accommodation to get pulmonary clearance? We should stop all this nonsense. Why expose the physician if he had symptoms to a procedure where we know the effects of COVID? If he wants religious accommodations, he should also get religious accommodation and not do the test. Why expose the providers to all this?
Okay, well,
we don't have an obligation to provide the test the procedure if he's not going to comply with our requirements. He can go elsewhere and seek the test. So he should be given a religious accommodation. And if he wants to have but he also should not be given, the procedure should not go forward. That's the bottom line.
So then you're saying he should not be given a religious accommodation.
Exactly.
Okay, I just want to make sure. So here's the results of the poll. 20% said yes. Overwhelming majority said no. 15% not sure. Yeah.
It's an elective procedure, so that to me is also something, I mean, is it different when it's an emergency versus elective? Patient is conscious, this is an elective procedure.
Well, if it was an emergency, I don't think there would be time to get testing.
I think they're going down a very dangerous road by refusing to look and analyze at this person's motivation. And if you look at OSHA rules and EECKC, it allows for religious exceptions. And I think
all right. So we are going to go over those legal documents. Let me.
think about all the other.
So let me. So you saw. So I spoke with the patient. Okay, and he said that UMMC policy states that patients will not be discriminated based on race, ethnicity, or religion. He feels his rights are being violated. I asked him to help me understand the religious basis of his objection. And he refused, saying he prefers to maintain his privacy about his beliefs.
What's wrong with that?
What do you mean, what's wrong with that?
I mean, he has, if the government recognizes, the federal authority, his religious exception, is it really our role to question him? I mean, you mentioned you didn't want to question the other person with the family APGAR. We don't have the right. Do we have the right? I mean, yes, try to ask.
I'm not performing a physical exam here. I'm just wanting to understand the basis of his religious beliefs. Now,
it's history and physical. When you talk,
I'm having a conversation with the patient, and you're implying a good thought that does it make a difference? So, good question. David Harness, I don't know if he's on the call, but he's a chaplain here, okay? And his thought was to seek a religious exemption implies that the petitioner belongs to a community which shares a body of beliefs, typically inspired by sacred texts and or teaching authorities, beliefs which are vetted, interpreted, applied within that faith community. Our petitioner appeared to have a personal objection to COVID testing, but offered us no basis to claim a religious exemption. So that's one side of the coin, okay? So let's go. Equal Employment Opportunity Commission. So they issued new guidance for resolving religious objection to COVID-19 workplace vaccination mandates. Each employee must approach each request on an individualized fact-specific basis and weigh the requested accommodation against any undue hardship it may cause on the workshop. And there is a religious accommodation request form. It's a one-page request form, and one of the questions is, please describe the nature of your sincerely held religious beliefs or religious practice or observance that conflict with the EEOC requirement, policy, or practice identified above. Now, I'm not really sure why they're asking that question, because according to the Title VII of the Civil Rights Act of 1964, the EEOC has said that the definition of religion extends to traditional religions as well as religious beliefs that are new, uncommon, not part of a formal church or sect, only subscribed to by a small number of people, or that seem illogical. I mean, it could seem illogical or unreasonable to others. So it's a broad definition of religion, and based on this broad definition of religion, I maintain that everyone on this call is religious in some way or another. So it actually probably doesn't make a difference about the where his beliefs are coming from. So how do we solve this issue? So let's look at the competing ethical principles. On one side, for religious accommodation, we have autonomy, right? It has his right to hold his beliefs, and they appear to be religious by his account, which is fine. On the other side, we have the principles of ethics. So which one of these principles come into play here? Not all four of them. Which one? I'm asking for a voice vote. I don't have a formal poll here.
Justice.
Justice? Okay. Why justice?
I mean, protecting others. Just
Protecting others. So maybe non-maleficence?
Well,
Yeah, non-maleficence.
okay, yes.
Okay, very good. All right, good comeback. So yes, right. So we have that undue burden clause that I mentioned before in the EEOC. And so essentially, well, thoughts on the chat box, but what do you think about that? So weighing autonomy versus undue burden on the workforce. So
I vote for the non-maleficence as well, because that physician has also the religious right not to expose themselves to somebody that may have COVID.
well, I never thought of that as a religious right. But
Well, that may sound illogical as well as his religious right.
And that's religious, I guess. Now, so what do you think? Is granting a religious accommodation
Viable.
presents an undue burden on the workforce?
Absolutely.
Doesn't have to, no.
Absolutely.
Yeah, absolutely. You know, I think we have to understand. I think we have to understand that the freedoms are not boundless. Anybody else's freedom stops where my freedom starts. So no freedoms are boundless. You cannot walk with a gun. You know, you cannot walk. You cannot walk
Right.
naked,
No, good point.
even if it's your religious belief.
This is a medical institution. You can't judge it by freedom of someone walking down the street with a gun or something like that. I think it's a very dangerous road to not allow him his autonomy and not come up with other strategies.
Yeah,
so
but his autonomy is putting me in
Wait,
danger.
hear me out. Pick a physician who, I mean, if you do this, what about people who had didn't get polio vaccination that came in? And not only that, remember that there were oral polio shots that gave parents polio. And so other people refused polio. It's too complex of an issue to force into such a box. I think he has a right to his autonomy. And as a medical community, I'll say last thing, we have a responsibility to somehow met out and meet those needs.
No, but
that
you're
should
mixing
include
testing and
everybody. It's
no, but
possible.
what you
Okay,
just said
all
is
right,
true for
okay.
vaccine,
Time out. Time
not for
out.
testing.
Great discussion here. So a lot of different thoughts, which proves that this has been or was a ethical dilemma. Okay, because you guys can't agree on this. Okay,
You know what the great
but-
ethicists say? When all think alike, nobody is thinking at all.
So, so how you resolve this dilemma is that one has to assign weights to the contrasting principles. And so one could assign a greater weight on the undue burden on the staff and other patients to not to grant the religious accommodation. Wait, I thought I had another thought, but so it appears that well, it appears that it all hinges on what we mean by undue burden. Now, it's interesting. The EEOC defines undue burden as more than a de minimis burden. So something like just above minimal risk, which is a low standard. Interesting, in the American Disabilities Act, they define undue burden as a significant cost or burden on the other person, which is the highest standard. But in the workplace, it's a de minimis, more than a de minimis burden. So if it was a low burden, all bets are off. But if it's something that's slightly higher than minimal, then that's an undue burden. Now, the staff also raised the issue, what happens if there is a complication to the surgery? He gets intubated, admitted, and now he presents a burden to other patients and other staff. Now, on the other side of the coin, someone raised the issue, well, the staff could put on PPEs, and that could be done. Our final recommendation was that the circumstances of this case does not justify a religious accommodation to be offered to the patient. That's how we weigh those conflicting principles. So the patient called me up a few days later. I told the GI staff on a Thursday, and Monday I got a call from the patient. He hadn't been told the results of the consult, and he asked me what was the results. And I told him, well, granting you an accommodation would be an undue burden on the staff. And he said, well, our policy says treatment will not dependent on religious views, cut and dry. So my question to you, should we be making changes to the policy?
No.
Are we in violation of our own policy?
Think so.
Or do we need a footnote? So just something to think about, something that I've been thinking about, because the policy does say that. But he also quoted the Civil Rights Act and the Equal Employment Opportunity Commission. So, and they have a footnote, they put down a undue burden. So I do find it interesting in the sense that I don't know, I can't think of any other example in which regarding race, ethnicity, sexual preference, in which a preference for race, ethnicity, sexual preference, giving treatment would present an undue burden on the staff. I don't know how an exception is relevant to race, ethnicity, sexual preference. But it appears that there is an exception to religious.
Isn't there a general OSHA regulation that the workspace should be safe?
Well, that's what I'm quoting from. The workplace should be safe. But all I'm saying is that we see here an example of where one does not grant, could not grant an accommodation based on religion, based on undue burden on the workplace. What I'm trying to say is I can't think of a similar situation regarding race, ethnicity, or sexual preference. If somebody could think of an example regarding the other categories, I'd be interested to know, but it just, this case brings up the exception to religious freedom, although our policy says cut and dry, we will not discriminate on the basis of religion. So anyway, the short story to this is that the patient, before he hung up on me, he said, "You'll be hearing from me." So this might be the last ethics rounds for a while. I hope. Okay. All right. Good. To be continued. I'll let you know if I get any pushback. But I'm glad the undue burden. Actually, in my consult note, I did use the word de minimis in my consult note because I looked this up before I wrote the note. So
Henry, if you get in trouble, Howard County would love to have you. We have an ethics committee. We'll set it up. You'll be the leader. We'd love to have you. Don't worry about it.
Oh, okay. Well, it's nice to know I have options. Okay, next case.
We'll come for your defense.
Yeah, absolutely.
All right. Well, I more than 70% of the people voted no, so the numbers count. Okay, good. Our decisions being made in the patient's best medical interest. We have a patient, 63-year-old female, admitted for right MCA stroke. She underwent a decompressive hemicraniectomy due to a midline shift. She also received treatment for a ventilator-associated pneumonia. There was eventually a concern for an infectious fluid collection involving the craniectomy bed and concern for ventriculitis. And the team recommended an LP to optimize antibiotics. However, the patient's healthcare agent, as appointed in an advance directive, refused consent due to concerns regarding the evasiveness of the procedure. The healthcare agent was also refusing trach and peg for long-term placement because she was concerned about the invasiveness of the procedure. POA also believes the patient can recover. So my question to you is, how vigorously should the medical team press for an LP? That's what the consult was for. Put in your votes. 5 more seconds. Okay, great. Let's have a few more. Here's the results. We have a quarter said greatly, the majority said moderately, and 20% said not much. Okay, good. So our thought was that, well, I had a phone call with the healthcare agent. She said everything is fine with her interactions with the neurology team and that she wants to take everything one day at a time. She reiterated that a trach and peg could be performed when the patient is medically stable to have these procedures performed. When I asked about the LP, she said she has her own source of information guiding her decisions. And that was a short conversation. You already did this poll. So our assessment was that, well, refusal of the LP would probably not set back the patient's best interest significantly because, well, one could do what we usually do, empiric antibiotics, but this could change if sepsis continues with progression to shock. However, tracheostomy is standard medical care and needs to be performed in a timely manner. If the healthcare agent refuses treatment that is thought to have a potential major adverse effect on the patient's best medical interest, then legal interest might be warranted. Okay, so thoughts about that assessment?
One thing to note, a lumbar puncture is very, very usually innocuous. The greatest side effect or a headache, I think studies report 20 to 30%, which resolves. And, you know, very rarely do you have to do anything else. So certainly that's not, I would not put that in as a major, I mean, I would wonder why they're so upset and what her legal, what her thoughts are about a lumbar puncture, because it's very reasonably safe.
Good point, but I agree with you. But think about this: to a lay person, they're being asked, "We're going to stick a needle in your spine."
Right.
That doesn't sound too good. Okay.
Right. So, they're not going to ask if it's ultrasound guided, or they're not going to know all the questions to ask for you. Right.
Ultrasound guided. Do we do that? Ultrasound guided?
It's supposed to be done. That's considered the state
fluoro,
of the art.
Really? You know, as a medical student, way back when, okay,
evidence-based.
That was one of the few procedures my residents let me do because very, very low chance of side effects. Anyway, 2 weeks later, well, just to fast forward this, the team wanted a trach and a peg for long-term placement. The attending met with the healthcare agent and she declined to provide consent, again, requesting that the procedures be postponed for non-medical reasons. And the attending explained that unnecessary delay could prove harmful to the patient. Will re-engage the ethics consult. Okay, so what happened here? So what to do now? So what do you do now? Just she's refusing trach and peg. What would you do now?
Doctor, here, Chandana again. So why is she not, if the prognosis is not too good, did the team discuss no code status? They're not just refusing LP, they refuse tracheostomy and PEG too. Is it correct to say?
So we have discussed code status with the patient multiple times, and the patient's POA feels that the patient can recover because she has known people that recovered from strokes in the past. But she does not understand that this is a severe MCA stroke that will likely not recover from.
they want.
Great. Thanks for that input. And you're right. On one hand, the POA believed that the patient will recover and walk out, but on the other hand, she was refusing these procedures, which gets to be somewhat frustrating. So, so the attending called me up 4 p.m. on Friday, and I advised to discuss with the POA that a trach and a peg represent standard of care, and if she is unable to provide consent, say this very non-adversarial, that if she can't provide consent, we may need to seek the input of the court. And so the attending did that, and the POA gave consent for the
Should we
trach
send it
and the peg.
Howard County,
So,
Lawrence?
Now, the story continues. Story doesn't stop there. Now, the issue is about discharge planning. And essentially, the POA was having difficulty being amenable to have the patient discharged to another care facility. Originally, she said only Midtown. That's a plus for the Midtown people on this call, I guess, because they have an ICU. So in case something happens, then she would have access to the ICU. But then, just last week, the POA was refusing any type of discharge because she was concerned that if her blood pressure drops, that would not be picked up. In fact, she told me that one time when the patient was in the ICU, the patient's blood pressure dropped, and someone told the POA, well, it's a good thing she was in the unit, because if she was on the floor, we would have never picked up the hypertension. So it's like, thank you very much. So anyway, so POA not willing to discuss placement at this time. She expressed concern that she would not be monitored appropriately for the blood pressure. She refused to sign papers to transfer until she improves and is unwilling to have a family meeting at this time. Palliative care said, the POA said that, the POA said she cannot receive updates on poor prognosis because it affects her mental health. If the POA is found to be unwilling, unable to make decisions, then a secondary POA should be contacted, not contracted. So it's palliative care discussed this with legal, and the concern was whether the POA is going against. Also, palliative care was concerned whether the POA is going against the patient's advanced directive. So here's the advanced directive. Sorry for the fuzziness, but the appointment of the healthcare agent, it does mention about if my POA is unable or unwilling to act, then I appoint my friend to make healthcare decisions for me. I'm not sure if one could say the POA is unable or unwilling. It brings up a good point. Maryland law has a long definition of what constitutes an unavailable surrogate, but I'm not sure if this language disqualifies her as the POA. Now, regarding going against the patient's wishes, the patient did state that if I'm in a persistent vegetative state, keep me comfortable and allow natural death to occur. I don't want any medical intervention. So there was a concern that we were going against the patient's wishes. However, life is not that easy. She also, there is also the usual clause in advance directives. My stated preferences are meant to guide, but I authorize them, meaning the POA, to be flexible in applying these statements if they feel that doing so would be in my best medical interest. And she did not mark this clause. I want my healthcare providers and whoever is making decisions on my behalf to follow my stated preferences exactly as written. So all advance directives have this type of clause in the advance directives, and usually they say on one hand, my instruction should guide, but they have flexibility. So what to do now? Well, ethics involved in this patient care early in the hospitalization, and we were hauled back then. And so ethics recommendations. So I wrote in the chart, if all issues are addressed and POA still believe the issues revolve around her perception of medical stability, may need to involve the judicial system, inquire whether the POA desire a second opinion. But I also wrote, may want to ask the following questions of the POA. Have there been any experiences that cause you to lose trust in the healthcare system? Many patients experiences racism in the healthcare. Are there any experiences you would like to share with me? I want to ask this group, this was in the recent diversity, inclusion, equity interest. Let me ask this poll, how comfortable do you feel in discussing issues about race with patients and family members? Okay, let me keep this open for another 10 seconds. Okay, let me 2 more seconds. Cast your vote. Okay, so a third said very comfortable, 45 somewhat comfortable, 21% hesitant, small, very small minority. I do not feel comfortable at all. I bring this up because, well, 10, 15 years ago, we weren't comfortable talking about death with patients. And now we want to make the implicit explicit because, Larry, you were talking about family app guard, but I think in the times we live in, and especially the population we serve, issues of trust and racism could very well be implicit. And I think that we need to make it explicit. Now, some of the questions you may want to ask, for example, many of my patients experience racism in the healthcare. Are there any experiences you would like to share with me? Have there been any experiences that caused you to lose trust in the healthcare setting? If I miss something important or say something that does not feel right, please know you can tell me immediately and I will thank you for this. Okay, this is new terrain. I should have asked another poll, how many people have brought up issues of trust and racism with their patients? I'm trying to move the ethics committee in a direction towards thinking about racism, inclusion, and diversity. And in fact, in the consult note, I have a question. Are there any concerns with discrimination or racism in this consult note? If you don't ask the question, you're not going to get the answer.
Henry, that's a great paradigm, but what about all the other isms? What about Orthodox Jews, Orthodox Muslims? And, there can be all kinds of discrimination. Why not broaden the horizon?
Well, I think that racism includes that. includes all that, right? Recently, Whoopi Goldberg said crimes against humanity involved white versus white, and she did not regard that as an issue of racism. To conclude, I spoke with the POA about her experience with UMMC. She asked me, what do you want to talk to me about? In a very pleasant way. And I said, well, one of the things we do is that we want to make sure families and patients are feeling good about their experience at this hospital. And she said she has no issues and considers UMMC to have the finest doctors and nurses. Again, think back in the beginning of this case. She kept on refusing LP, trach, and PEG against medical advice, and but we couldn't understand this, and because she believed the patient would wake up and walk out, and she asked me, why am I asking? And I said, well, some families, patients have had issues trusting the care that they're receiving. And am I assuming that is not the case with you? And say, oh, no, not at all. I trust everybody here. No problems with that. And I thought she was very sincere. And I think that if there's no issue with trust, correct me if I'm wrong, one basis for mistrust is due to experiences with racism. And so I did not move forward with the issue of racism in this particular case. So again, my final thought is that I'm trying to include this diversity, inclusion aspect in ethics consults, and I'm partnering with individuals at social work who are leading that charge with their community members, and I'm trying to get people from the community to be on the ethics committee because I think their lens are wider than ours. So any final thoughts? I really appreciate all of the interaction. I'm sorry we couldn't expand on a lot of those thoughts. Any final thoughts?
Great job.
Nice cases.
Oh, thank you. Great. This is just the tip of the iceberg, trust me.
Did we ever get to address the advanced directives of the patient?
Oh, well, yeah, we addressed the advanced directives, and one, I did not consider the POA to be unwilling or unable, and one, she was giving the healthcare agent flexibility in the case, and again, most, if not all, advanced directives have that clause. Healthcare agent has that flexibility in the best interest of the patient, which, by the way, for another day, I like to bring up that there is now a movement, if I could use that word, and that's gaining traction. And personally, I do agree with it, is that all this stuff about advanced directives has been really not very useful. Now, appointing an agent is, but leaving these instructions is not useful. In fact, I have to run over to the hospital. There's a case in which this patient with advanced cancer, metastatic cancer, she's now intubated, blah, 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 and her advanced directive, let me end with this final thought. Her advanced directive says, I want everything done to prolong my life, absolutely everything. So legal is recommending, well, Maryland law has this futility clause, and hence you don't have to provide treatment that you think is futility. So what do you think? Could one use the futility clause in Maryland law to overrule, if you want to call that overruling, that provision in the advanced directive? I'll let you know what happens with that case next month when I have my next edition of Ethics Round. Thank you so much for
Thank
your
you.
thoughts.
Thank you. Great.